This is the pediatric assessment section of the CPEN exam review. In this section, it'll cover 25 questions on the exam, which is about 16, almost 17% of the exam. The blueprint for this section will cover the history and physical as well as pain for the patient. So as you can see on the screen, there are the blueprint objectives that we'll cover. We'll also cover the neonatal emergency section, which is actually in another blueprint section, but it fits better in this section, so I'll cover that here. So technically, there's a little more covered in this section, but that's okay. But we're going to put neonates here when we talk about developmental milestones. All right, let's jump in. So let's start with the challenge question. So your first challenge question here, which of the following findings is most concerning in a 2-year-old child? A, a pulse of 130 beats per minute. B, a systolic blood pressure of 86 millimeters of mercury. C, an end-tidal carbon dioxide of 40 millimeters of mercury. Or D, a respiratory rate of 16 breaths per minute. Give that some thought and see if you can come up with an answer. All right, we'll start with our primary and secondary surveys. So, quickly looking through, now you've done primary and secondary surveys in any of your standard core curriculum. So as you've heard me say, or I'm sure you know, your core curriculum is obviously on the test. I'm not going to reteach you all of those. So you know your A through I mnemonic, but what I want to talk about is some of the warning signs, some of the specific things in each one of these sections that might stand out and might be something that we want to specifically look at in the child. So in your alertness and airway section of your physical assessment, watching for things like apnea, choking, drooling, because when you're looking at these things, so if they're not breathing, apnea, right? Obviously, that's trouble, right? But why are they not breathing? That's the key. So in a kid, you want to use that as a springboard to dive deeper. So not breathing, is this a neonate that might have some sort of neurologic finding? Is that also related to some sort of adventitious breath sounds? Maybe there's an obstruction. Maybe they're fatigued. Maybe they have some sort of congenital heart defect and they just are fatigued. They're out of energy. So watch for what is leading to it. You might also see normal findings of apnea, like in the newborn. Apneic periods lasting up to 20 to 30 seconds, actually a little longer than that. But I always say 20 to 30 because any more than that, my pucker factor is going off and I can't go any longer than that. But watching for that could be considered a normal finding in those ages. Drooling. Why is the kid drooling? Looking for other signs, digging deeper. Is this something like epiglottitis? Are they teething? Is this, an infant? But they could be warning signs. So you have to then apply it to the developmental stage and see what is it. Audible airway sounds, almost always, this is going to be problematic, but again, the positioning. So what's demonstrated there on the screen is tripoding. That again is usually going to be a classic warning sign of distress. Now, your breathing and ventilation, your warning signs usually, and I mentioned this in another section, but looking for things like grunting as they auto peep, increased work of breathing, irregularities in the pattern, cyanosis. Now, cyanosis is going to be more of a circulation to the skin thing, but when you see it, it could be stemming from their ventilatory ability and a respiratory failure rather than a circulatory problem. So it might stem from either one. Now I put respiratory rates there. Now these are just generalizations, obviously, but any respiratory rate greater than 60 for any child, that's going to be a problem. But bradypnea, less than 20 in a kid under 6 would be alarming, and then less than 15 if they're under 15. So that's generally how you're going to look at the range for respiratory patterns. Now that's, again, very general rules, right? You can, in your manual, if you have the manual, you have a much more specific set of guidelines driven by the American Heart Association. But those are based on studies. They're not linear. They're kind of all over the place, but they come from actual data, which is great, but who the hell wants to memorize all that, right? So you have to find something that's going to give you a ballpark so you know when to question it, when this is worrisome. I mean, I don't know anybody who is infallible and knows, every assessment finding for every age available. So I like to give myself some general guidelines so that I know when to worry. And that's what I want to help you with. Okay, so circulation and control of hemorrhage. So remember, TNCC is going to add your hemorrhage control, of course, so it used the C there. So I just threw it on the slide for that. But circulation is mostly what we're going to look for. Now you can see that circumaural cyanosis there in that picture. But this is going to cover the whole spectrum of skin here. So looking for cool, clammy skin. So this is going to be your sympathetic stimulation. Cool being vasoconstricted, clammy being diaphoretic. Both will be sympathetic stimulation. We'll talk more about that in another section. Your tachycardia or bradycardia, right? So we'll talk about heart rates in just a second, or vital signs in general in a second. Hypertension, again, we'll talk about specifically how do you know when pressure is too low. And then your peripheral pulses. In the cardiovascular module, we'll specifically talk about why and how that diminished pulse is so critical in kids and why it shows up so fast and so differently than their adult counterparts. So the other piece might be decreased tears. So the opposite of that, if they're producing tears. So kids will very commonly stop producing tears when they become dehydrated. So the fact that a child is still producing tears when they cry, that is a good thing. And when they're not, when they're crying without tears, that might be a worrisome sign. So now bad acting is also something that could be there. So, dry crying is sometimes a sign of poor acting, but, on the test, they won't have poor acting. So, and then sunken eyes, that's a little more subtle, hard to describe, but when you see it, you know it. And then disability. So remember disability or de brain, this is going to be a brief neuro assessment. So you can see there that bulging fontanelle indicating increased intracranial pressure. So watch for changes in mental status, inconsolability. Now this could also be decreased mental status, but inconsolability is usually what you'll see in small children, that irritability. But bulging or sunken fontanelles could be sunken for dehydration, bulging for increased ICP. Okay. Now, exposure and environmental control. The first part, exposure, is so that you look at the child. So part of the initial assessment is making sure that you're actually looking. So commonly, historically, one of the biggest mistakes we can make with kids is you're not actually assessing them. You cannot do an assessment on an infant while they're in a sleeper in their car seat. You cannot assess them if they're still strapped in their car seat, sitting on the bed or on the floor next to the parent. You did not do your assessment. You did not see them. You don't have X-ray vision. You did not look through their clothes. You have to expose them. You have to look at their body to see them. Please stop being that nurse, right? Look at the kids, and that's what exposure, and it's really for everybody, but kids, because remember, they're not going to necessarily tell you everything. You sometimes have to go looking for it. And then environmental control is super important, just as important as exposure is in kids. Controlling that environment is so important. The younger they are, the more important that is. Their heat loss, the inability to thermoregulate is so much more of a factor the younger they are. Now, the other signs would be their non-blanching rashes, which would be petechiae or purpura. Petechiae when it's very small, purpura when the bleeding into the tissue is larger. We'll talk about that. We'll talk about that in the integumentary module, but in rashes. But the other piece here is remember to always be cognizant of signs of abuse. So in your initial assessment, we always, not that all kids are abused, but very important when you're looking everywhere, making sure you're objectively documenting anything that might be a potential sign of abuse, okay? So full set of vital signs and family presence. So with this one, the main thing I want to focus on this part is just the temperature. We'll get to the others in a second. So hypothermia is always going to be worrisome. Now in the neonate, we'll talk about that in a few minutes, cold is probably more common, being colder than warmer, but for higher temperatures. Now for your early infant, neonate and early infant, so less than 3 months, we have a slightly lower threshold for fever. So anything over 101, so 38.6 Celsius or 101 Fahrenheit would be worrisome. But any temperature over 40 or 104 at any age is going to be our worrisome area. And the reason for that 40 Celsius is that the hypothalamus, which is what regulates our body's temperature, sort of our furnace, it's sort of our HVAC, I guess, for the body. It tries to heat and cool us based on the set point that our thyroid sets for us. But once the body rises above 40 or 104, then the hypothalamus stops working. So it's unable to cool us back down. So that's why you have to intervene on a temperature above 104. Now, it would be the same for adults, but most adults can't generate a temperature that high, but kids can. So that's why we mainly talk about this in kids.